Hello, everyone. Welcome to the Global Gastroenterology. Today, we welcome Dr. Ricardo Badillo. He is interventional gastroenterologist with Providence Gastroenterology and Liver Associates. Thank you, sir. Thanks so much for giving us your valuable time. Could you please introduce to our audience that how many experiences you have and where you currently work?
Absolutely. Thank you for inviting me to this talk. My medical school was out of Texas Tech University in Lubbock, Texas. My internal medicine residency was done at UT Southwestern in Dallas, Texas. And then my gastroenterology fellowship was completed at the Washington University of St. Louis. And my advanced endoscopy fellowship was completed at University of Michigan in Ann Arbor, Michigan. After that, I worked 4 years at the Texas Medical Center as a professor at UT Houston, and then 3 years as a professor at Texas Tech University in El Paso. And now I'm working with Providence Gastroenterology in El Paso, Texas.
Impressive, doctor. So, doctor, our platform is mostly for the public awareness, and we just discuss the common challenges the patient face, and we provide them the scientific evidence-based knowledge. So, we will start from as you are from native El Paso. So, what do you think? What kind of challenges patient face specifically in the El Paso and nearby areas from the gastroenterologist standpoint?
Yeah, so El Paso is located in the far west point of Texas. It's across the border from one of the larger cities in Mexico called Ciudad Juarez, Mexico. And essentially a border town just with a river separating them. So a lot of the challenges that we see here is primarily education or medical education, medical care education in patients that live in the city. We have a lot of patients that have never seen a doctor their entire lives until they ended up getting sick or having severe symptoms. Um, Having regular scheduled primary care visits is challenging for a lot of these patients. Many of them work, many are uninsured as well. And some also live and work out in Mexico. And so there's difficulty there with follow-ups with these patients and lack of insurance or Medicare.
Yeah, doctor. And we also receive some patients from the underserved areas of New Mexico, I guess.
That's right.
And yeah, so it's really a diverse patient population, and we have like different challenges dealing with them. So, doctor, as you are mostly into the intervention, so we will use this opportunity to have this discussion mostly towards the interventions in the gastroenterology. So, we'll start our discussion with the esophageal cancers. Can you please give us, our audience, some advice? What are the risk factors and how we can prevent the esophageal cancer?
Absolutely. So in the general population, esophageal cancer risk factors include things such as smoking, tobacco, alcohol use are all risk factors for developing esophageal cancer. Um, In other patient populations, specific patient populations, it could be diet related, such as the Asian population and Asian um, ancestry. They have a higher risk of developing esophagus cancer, primarily diet related due to processed meats, smoked meats, and such. And then in other populations, we have the risk of developing a Barrett's esophagus from long-standing esophageal reflux. With the changes in the Barrett's esophagus, it increases the risk of developing esophageal cancer in the future.
So now we are talking about the GERD and the reflux. So I just wanna clarify some misunderstandings. So we see patients a lot of the time they are on like on PPIs, omeprazole, famotidine for a long time. So do you have any advice which patient should getting the surgery done to prevent the GERD, and which patients should are okay with continuing the omeprazole, understanding the risk they have?
Yeah, so you're absolutely right. There's been a lot of studies that have come out over the last decade about the associated risks of taking medications such as proton pump inhibitors for a long time. Medications like pantoprazole and omeprazole. Um, some of them have been causal effects, that we've seen on those studies. And so patients are understandably worried about taking the medications for a very long time or their whole lives. But we do see patients have a really good benefit in taking these medications for a prolonged period of time with minimal side effects. We do understand that there could be risks of osteopenia or developing osteoporosis in patients that take proton pump inhibitors for a long time. Risk of gastrointestinal infections also possible, and also risk of pneumonias are also possible. So we always have to outweigh the risks and the benefits of continuing medications such as pantoprazole in these patients. In terms of who I refer for fundoplication procedures, knee fundoplication procedures, um, there are going to be patients who aren't able to tolerate PPIs for whatever reason, severe osteoporosis, patients like that. They, of course, need to be good surgical candidates for the surgery. And other patients, other criteria that we use can include just severe symptoms despite PPI therapy. And it's confirmed that the symptoms are related to reflux. Those patients do really well with Nissen fundoplications. Um, those are the main patients that I refer.
Sounds good. So now, if a patient decides to go for the fund applications, what kind of workup he needs to be done before going to the surgery, and what kind of workup he needs to be a qualified candidate for the surgery?
Yeah, so we need to make sure that when we're talking to the patient, we obtain a full history and physical examination of the patient to determine their candidacy for surgery. We need to perform an upper endoscopy to take measurements to see the size and location of the hiatal hernia. We also, at that time, can take biopsies, rule out things such as Barrett's esophagus, which would prevent the patient from getting fundoplication, and of course, cancers that could be incidental findings as well. After endoscopy and we obtained our measurements, we typically order esophageal manometry testing to make sure the patient doesn't have ineffective swallowing that could worsen after fundoplication surgeries. We also want to confirm that the symptoms are related to reflux because those are the patients that do best with fundoplication, and that could include things such as pH testing with Bravo testing or pH probe testing, or if you have evidence of esophagitis on biopsies, can also be sufficient.
All right. So, doctor, do you have any referrals, any surgeons, medical centers, private groups to refer, like surgery for the fund application?
Yes, here in El Paso, we primarily use the Providence Surgical Associates. They have a lot of experience doing surgery such as fundoplication, um, and they have really great outcomes.
All right. And now, if unfortunately a patient develops the esophageal cancer, do you have any referral for the oncologist or the surgeons who deal with this kind of surgeries?
Yeah, so we're looking at El Paso that we have multiple adult oncologists in the area. That includes university, Texas Tech University. That includes Texas Oncology and a few other private practice oncologists. All are very well trained, and I trust them all with my patients and their care.
All right. And thank you so much, doctor, for sharing all this information. Now we'll move over towards our next section is the pancreas cancer. So what kind of people can get the pancreas cancer, and what do you advise if they find any incidental findings in their pancreas?
Yeah, so screening recommendations are still an evolving area of research of topic for pancreas cancer screening. We know that there are certain conditions, genetic conditions that can predispose patients to have a higher risk of pancreas cancer, such as having a family member, especially first degree relative in their family that had a history of pancreas cancer. Those patients should be screened for pancreas cancer. Other situations in which I recommend screening for patients are those with chronic pancreatitis. There is a notable increase in the risk of developing pancreas cancer with patients that have chronic pancreatitis. Um, Pancreas cysts, some cysts can develop into cancer, some cysts will never become cancer. And it's important to differentiate between the two with imaging or endoscopic ultrasound with biopsy. However, this can be difficult because most pancreatitis are asymptomatic and are incidental findings. But when we do find them as part of workup for other abdominal pains or such as that, we can follow up those patients, perform endoscopic ultrasounds or MRIs, and determine whether surgery is necessary or not, or we only, do serial imaging monitoring for these patients.
All right, doctor. So unfortunately, if a patient develops the pancreas cancer and we refer him for the Wimple procedures. So it's a pretty big procedure and it has its own complications. And do you want to share your knowledge? What should be the expectations after the procedures and which are the best medical centers in the Paso for having the procedure done?
Yeah. So, yeah, very unfortunate when patients develop pancreas cancer. It usually presents really late. However, in those lucky few patients that are able to qualify for Whipple surgery or distal pancreatectomy or wherever the cancer may be, it's essentially a multiple specialty, multiple disciplinary care for that patient. Um, we have two great surgeons in El Paso that specifically focus on pancreas cancer. Um, and I usually refer my patients that are able to get surgery to those surgeons. Um, there's also some movement in terms of recruiting people into the university nearby. And so hopefully soon they'll have another surgeon available for that as well. But like I said, it's multiple disciplinary management of these patients, including GI, um, oncology, and surgical oncology.
Definitely, doctor. So, as you mentioned, one thing about a chronic pancreatitis. So, I just wanted to have your advice if the patient has a chronic pancreatitis and is suffering from a pain for a long time. What do you recommend about the celiac plexus block? How does it work and how long it lasts?
Yeah, so chronic pancreatitis can be very debilitating in terms of long chronic pain. So we have several options in these patients. We can do treatments such as medications, including medications such as gabapentin, pregabalin are good medications for this. There are some studies that show medications such as pancreas enzymes supplementation could also help decrease the work that the pancreas is doing and therefore decrease the amount of pain the patient is getting from the chronic pancreatitis. And then, of course, we have endoscopic or IR guided celiac plexus block. So both are an option. Um, Outcomes are do really well. Patients with do get celiac plexus block for chronic pancreatitis pain. Uh, Usually, it lasts about 3 to 6 months, after injection, after the procedure is completed, for the pain to be, somewhat relieved. Usually what we notice is that there's not a complete decrease in the amount of narcotics or pain medications used by the patients, but we see a significant drop-off in the amount of narcotics and, non-opiates that the patients are taking at home.
Definitely, doctor. That's really helpful. And so now we'll move to our next section is the colon cancer. So as a native El Paso, what do you think? What are the trends in the colon cancer? It's like you have worked in the other areas of the US. So what do you think the prevalence of the colon cancer in the El Paso and how patient can get the screening because of being the underserved? A lot of patients doesn't have insurance. So how do you think of the colon cancer?
Yeah, in the small studies that we've done here in El Paso, you're absolutely right. We've noticed that the underserved community here that we take care of, we start to see more advanced cancer. Metastatic disease is very common in patients who present for the first time for symptoms that they may be having. And so, therefore, medical education is very important for these patients so that they can get appropriate cancer screenings and try to prevent this from happening. But overall, we see similar patterns as to the rest of the United States, um, where starting at age 45 to 50 is when we start to see a slight increase in the development of risk of colon cancer up until the age of 75. But we're also seeing younger patients in the 40s and 30s with rectal cancer as well. So it's really important to talk to these patients to obtain good history from these patients in terms of their symptoms that they may be having and have a low threshold for performing colonoscopies in the patients that are having symptoms such as hematochezia, weight loss, especially if they have a family history of it, colon cancer.
All right. Thank you, doctor. So now as a general, if a patient develops the esophageal cancer, stomach cancers, or like the duodenal cancers, what kind of palliative options they have?
Yeah, so from a GI standpoint, we can do minimally invasive procedures. So if it's a luminal cancer, we can do stenting with fully covered, partially covered, or uncovered metal stents that are self-expanding. We can treat their pain with things such as celiac plexus block for pancreas cancer. Um, Other things that we can do is control bleeding with endoscopic techniques, such as hemostatic spray, is certainly an option. And with peritoneal carcinomatosis, those patients can undergo a percutaneous drain placement in the peritoneal cavity to allow some symptom relief in for palliative purposes.
All right. Thanks so much, doctor. This is really helpful. And now it's just one question we ask our every guest. Do you have any advice for our healthcare providers as gastroenterologists, aspiring gastroenterologists, or physicians, how they should be managing their work-life balance and what's the thing you do?
Yeah, I mean, work-life balance is very important. Decreasing the amount of stress is very important. Finding times to decompress is very important. Burnout is a very real thing. So it's important to have someone or something that will help relieve that stress, whether it's a hobby, whether it's being with your family, travel, is very common amongst the GI doctors. So it's really important to take care of oneself while we're also trying to take care of our patients.
All right, definitely. And here we will conclude our session. Thank you so much. Really appreciate your time.
No problem.
I'm really thankful.
Yeah, thank you so much.
All right. Have a good day.
You too.